How do you reel in the insurance industry? They've got huge power. I don't know. I saw it coming, but the powers that be in organized emergent didn't realize that the insurers would say, why don't we own the physicians? And now Sound Physicians owns emergency medicine. Optum, 10% of all physicians in the country are owned by an insurer. Is that crazy?
Healthcare providers are experiencing a massive financial strain brought on by big health insurers. That's why we are embarking on a journey to unravel the complexities, challenge the status quo, and find solutions to economic challenges that have been plaguing physicians, hospitals, and others for far too long. Welcome to The Strain, winning the battle with big health insurance.
Welcome to The Strain. I'm Eliot Listman, and with me is Jim Blakeman, a 40-year veteran of the fight for fair physician economics. Jim brings a unique and insightful perspective. Our guest today is Dr. Bob McNamara, Chairman of Emergency Medicine at Temple University, and the founder and past president of the American Academy of Emergency Medicine. Bob has passionately advocated for the rights of emergency physicians for over 30 years. Bob, thank you very much for joining us.
All right, my pleasure.
Yeah, it's great to have you, Bob. It's a wonderful opportunity to take this conversation forward. A conversation you and I have had many times over the years. I'm looking forward to your insights here.
Sometimes to understand how to solve a problem, we need to understand historically how the problem has evolved. And I was hoping to kick it off with a question to get you really to share your experience and illustrate how things have changed over the years from when you started in emergency medicine.
Yeah, so I finished medical school in 1982, finished my residency in 85, took the path of pure academics, took the lowest paying job offered to me out of residency to stay in a teaching program, rose to the position of residency program director, where you bring the medical students and you take them for 3 years, 4 years, and make them into full physicians. Along the way, I found out about the real world of emergency medicine. Literally through the publication of a book called The Rape of Emergency Medicine. Probably wouldn't title it that these days. And essentially what it detailed in the book was a situation where young physicians go out, work for somebody, and essentially get exploited economically. So I did a little bit of research. Like I'd have a resident go out and they work a place for a year and be disillusioned within 1 year and then want to switch jobs. I'm thinking, what's going on out there? Like emergency medicine is great. We're here at the academic center, we're doing great things, but there was an undercurrent of discontent in the practice world. So I sent a survey back that was in the original book. It wasn't even published under the name of Jim Keeney. It was the Phoenix. So I sent the Phoenix my survey saying, look, I'm an academics, but if half of what you're saying is true, I ought to get involved. And he called me up and sent me back the other surveys. And I saw that the practice world was pretty screwed up. After 9 years of abuse, I'm leaving emergency medicine. Leaving my EM residency was like leading a lamb to the slaughter. I thought, wait a second, what's happening out there? Like we're training people that are going to leave after 10 years, like when they're going to hit their peak. The difference is back then, this was all physician driven. So all this stuff was going on and then the debate was shut off. Can't discuss this. Silence the press. So I did the research, contacted Keeney, and I said, I got to get involved. And then as, we've moved over time, it's gone from physician-owned to now we've got private equity, which is just insane in my view to have, a pure profit-seeking company in a specialty where we're caring for the most vulnerable in society. But more and more, I've realized that, trying to keep the practicing physicians whole, make sure that they're staying longer in a career is going to be better for patients than, me saying something about the use of magnesium in asthma. So I kind of adjusted my career to that. I think this is important as an academician to get involved because I'm protected. I can speak. I have tenure. Not many EM docs have tenure. So it's not a risk to me. I just saw it as a purpose that was worthy of engaging in.
Bob, just as a follow-up to your point about in the early days, you saw physician-owned groups being somewhat exploitive of other physicians that they employed. How do you see the difference between how the physician-owned groups treated the physicians they employed versus private equity?
Yeah, so there's a range of things, of course. I mean, obviously, we had the situations where they would call it the dictator, the one doctor who owned the contract and would just, these are my terms, I'm going to pay you an hourly rate, I'm going to make money off of you. And then some of them were called the benevolent dictator, where, hey, everybody liked the guy, you got to go to his fancy house for the big holiday party. Obviously, at that time, there were still physicians, they still sort of swore an oath to the patient. Once we moved to private equity, it's clear that they're beholden to their investors. So it radically has shifted over time, sort of this more benevolence to now it's just strictly business. Doctors feel like cogs in the wheel. I mean, we had exploitation in the past, but you didn't have the burnout, the feeling of we're just working for the man. That's what the specialty has become in large part. Surveys of emergency physicians show that they want to work for what they call a democratic group, a physician-owned group where they become an equal. So the underlying principle is that this is a very difficult job. And anybody who's an EM listening to this, and probably anybody in the community, understands that when you're working 24/7, holidays, you're there nights, weekends, and what you see in the emergency department, you see sudden death, you see violence, the ills of substance use, the fentanyl crisis that we have, young people dying. Like, how many doctors get to walk into the room and tell a mom their 16-year-old was shot and killed? And it's a difficult job, and you can't do it long-term if you feel you're being taken advantage of. That is the fundamental reason that I am so involved in trying to right the practice world, because I don't think we can survive. And the statistics are showing that we're not doing well. Now, the average career of emergency physicians now, it's 20 years. That's terrible. And it's even worse for women. Okay, women are retiring, according to the recent Gettle study, 12 years younger than men. It's a statistic that I still can't wrap my head around, but I understand what's behind it.
When did you first see private equity as a key influencer in emergency medicine? And how has that evolved over time?
Right. So, I mean, if you look at the progression, it was a large physician-to-own group. MCare, which, went to Laidlaw, and then Laidlaw sold to Onyx, and then the ball started to roll. Team Health, went to the Blackstone Group, and so now we've got KKR with Envision. The original sale was in 96, right, to Laidlaw. So it's really, this is a phenomenon of the late 90s to 2000s. And look, physicians are part of this, okay? Doctors that are my age, they're saying there's, all this cash being floated around. If you sell us, you're going to get your retirement nest egg. You're going to make millions of dollars. We're going to take over the business side of it. You're not going to have to fight the insurers. We're going to have the cloud. We've got the expertise. And, looking at it sort of like a business thing, like if you had built up a business and like, hey, somebody wants to buy up my company, that's the American way, right? I mean, that's, hey, I built up this small thing. I had a startup, and now the big company Google wants to buy me. That's fine. But what happens here is we're talking about patient care. So the young physician walks into that, they're paying off the debt, and they're paying off the 20+% profit that private equity needs to meet its mark, right? That's why people invest in private equity, send their money there. And so it's just created, it just ratcheted up. Oh my goodness, we've gone from physician owned, unequally owned, but now we are into a mode where you're working for a company, a corporation who's going to influence the bottom line. And emergency medicine is not really difficult to run, right? We don't hire the nurses. We don't have to rent the ER. Okay, the hospital supplies that. They pay the electric bill. They give us the EMR. They're using our ability to take care of patients, and they're taking money off the top of that and squeezing us. It's distressing to me. I think this is the greatest specialty, in its purest form. But I see what people practice under, and it's just, it crushes them.
Bob, what do you see as the big economic changes that we need to kind of lean into from a physician emergency medicine perspective to be successful going forward?
So, I lived through the prudent layperson era, right? I don't know if, Jim, you were there for that, right? So insurers would deny after the fact bill. Somebody would come in with chest pain, and we do a workup thinking they might have a heart attack. And it was a muscle pull, right? So they wouldn't pay us. It's ridiculous, right? And we had legislation passed, and we all put our efforts towards that. the insurers just want to make money, right? They're just like private equity. Okay, they're profit driven. Then we got private equity on top of that. And then we have the situation of the emergency physicians being powerless to deal with things like crowding. Okay, so the economic pressures on emergency physicians are huge. The workforce is under siege, and you're trying to cut their pay. And they are seeing the most needy patients in the country. The insurers, unfortunately, I believe, are seeing us as greedy emergency physicians. And that is not what the rank and file emergency physician is. I mean, we run a residency here in North Philadelphia, the poorest section of the poorest big city in America. And our residents all have a strong sense of social justice. They are not here to make a lot of money. They are here primarily to serve the needs of a needy population. We need to sustain adequate salaries for a difficult job. And we've got these multiple things going on. The whole No Surprises Act thing, we could talk about that, but we're to blame for that, in my view, because we allow private equity in, and they abuse the out-of-network strategy, which had existed. We were doing out-of-network since day one, when the insurer would be unreasonable. Like, everything was going along fine, and you played the game, and eventually they come back with a reasonable rate, as proved by Zach Cooper, who's a lot of people dislike him. He's a Yale economist, but he basically showed that when a vision would go into an ED, they go from 0 to 100% out of network, and that's just to make more money at the cost of the patient. Patients complained, legislators took notice, the insurance industry rode that wave, and we lost. Now the insurers are saying, we got the NSA, we can screw everybody. You're affecting a physician population that's already under stress from doing a difficult job. I said 20 years is the average career. That means people are leaving at 10 years. That's a tragedy. The best doctor you want taking care of you in an emergency department is not me, okay? And it's not the first-year doctor. It's that 10 to 15-year doc, the ones that are deciding, I still got time to do something else. I'm going to leave this pit.
Bob, how are you seeing the economic challenges impacting the direct patient care? Are decisions being made to reduce physician staffing, alternate providers, PAs and NPs? What are you seeing from the physician side?
Okay, so the number one expense in emergency medicine, board certified emergency physician. Okay, family practice docs will work for less than us. I said, you got to understand this. In the equation, you are the most expensive thing for the company, the corporation, whoever owns that contract. First off, they're going to squeeze you. They're going to try to have you see more patients per hour, which may be unsafe. And secondly, they're going to try to replace you with a cheaper caregiver. You know that when American Physician Partners went bankrupt, their slideshow to lenders got leaked, and they said, here's what we're going to do. There's going to be a physician oversupply, so we're going to be able to hire younger doctors who will be cheaper than those senior doctors. I can tell you, I was on a phone call last night with a physician, and the essential situation was he was one doctor supervising 3 non-physicians on shift. She did not have time to fully see that patient. It was an economic decision to replace the double cover doc. So a doctor didn't get to see that patient to the adequate level that that patient deserved. To me, that's a real key thing. Determining who sees the patient, to me, is the practice of medicine. The company's saying, well, I can make more money if I get rid of this high-priced board-certified emergency physician. And it's going on with private equity everywhere, right? If you see them, what they've done in nursing homes, cutting staff, what they've done in dialysis centers, your veterinarian. I listened to a Freakonomics episode. Can you trust your vet? They're owned by private equity. Your dog's healthcare, they shouldn't be in the healthcare of, your grandma. So it just doesn't make sense.
Bob, can you share with us how impactful you've been using your organization that you created to make changes, to advocate for change?
Let's clarify one thing. The true founder of the American Academy of Emergency Medicine is Jim Keeney. I was on his original board of directors. I said, Jim, if you change it to being all board certified, I will not only I'll join your board of directors. And that's really the move to going all board certified. That really took the membership sky high and gave us a footing to have money, to have a voice, to say we're 2,000 people now, not just he had less than 100 members. So Jim was, he was the founder. I just kind of helped him mold the vision. I actually wrote the mission statement, which is pretty much unchanged. Initially we just started off like, we want to fight that board certification and we want to fight exploitation, et cetera, et cetera. Catholic Healthcare West, now called Dignity, essentially bought a local contract group and wanted to take over all their EDs, employ all their docs in this hospital-owned entity called Meriton, where they were going to take 15% of their professional fees for profit. These docs are like, holy, our way of life's going to go. They turned to the American College and they were told it's a private business matter. They came to us, we said, hey, this is actually, you can't do that in California. Hospitals can't own physicians. Corporations can't own physicians. So we've been able to be a voice to say, this isn't right. Like private equity is not okay. We've been able to support groups from takeover. It could be just an individual situation, a letter writing campaign, a threat of getting involved, to the point now where we're actually committed a huge amount of money to sue Envision in the state of California, alleging that they're illegally practicing medicine through a front professional association. I'm also a founder. I'll give credit to Mitch Lee, Dr. Mitch Lee. Mitch got kicked out of a social media site for doing what I was doing for 30 years, complaining about corporate practice. And I said, Mitch, start your own. And now it's called Take Medicine Back. And we've got anesthesia, radiology. So we're fighting. So we're going to, litigation is one thing. The FTC alerted. They've sued U.S. Anesthesia Partners, Welsh Carson Anderson Stowe, private equity backs them. Michigan AG letter sent by the Michigan State Medical Society. That is grand. We've got a bill in Florida. We've got a bill in Oregon. So we're working on the state levels, trying to get the existing prohibitions on the corporate practice of medicine strengthened. It's just, we can't have the managers in charge of the physician. We can't have them deciding, who is going to see the patient. All that's fine. Medical group management, assisting physicians in their practice is a good thing. It happens in other specialties. But when they're in control, that violates the corporate practice of medicine prohibition, which essentially says the business influence should not be between the physician and the patient. Lawyers have the same thing. Lawyers can't be owned by corporations. So, what's more important, lawyer-client or physician-patient? I would say the latter is much more important.
Where do you see physicians pushing for what you've called for years? And that's greater transparency in billing and payment processing and accountability in the billing process. Do you have any insights into what the practicing physician can do to promote greater transparency and accountability in the billing process?
Yeah, for the individual physician, it's really tough, right? They can terminate you at a moment's notice. And we know the physicians who have asked to see what's being billed and paid in their name have been told, you don't want to really see that. We're not going to show you that. And then, you know what? We're just going to fire you. And we'll bring in one of those cheaper, younger physicians. Every one of my docs gets to see what's billed and paid in their name. And they realize that, well, we bill a lot, but we don't collect a lot. But they feel like they know what's going on, like that nobody's ripping them off, that they're getting a fair salary for their efforts. We tie to the salary surveys of the American Association of Medical Colleges. If you read what CMS puts out, the government puts out, doctors are supposed to see what is being billed and paid in their name. It's in the Code of Federal Regulations. But like I said, if you ask for that, you can be terminated. So I don't think the individual physicians can do anything about it. The government, the insurers, they could do this stuff. They could mandate that every single physician sees what is billed and paid in their name. The RCM companies, Jim, right, they've got that information right at their fingertips. It's a push of a button to send that to a doctor. Once a doctor sees, wait a second, I generated this much in professional fees, it's going to change the game radically. They're going to say, oh, wait a second, all right, were these bills fair? And then secondly, I generated this much money, and why did you take so much out? What did you give me in return for that? So it exposed fee splitting. So doctors, working for these companies, they have a fee splitting action. I have been forced to sign a contract that makes me give up 20, 30% of my fee for the right to see patients. That's a kickback. It's a sticky wicket, but that's the way you can read it. That's the number one thing I would do. I would say transparency. Every emergency physician will see what is billed and paid in their name. Simple. It'll end gender discrimination, right? I just talked about women retiring 12 years earlier. Like, why wouldn't you want this to have this kind of transparency? And then we could be a check on fraud. That's what the government expects, that we're going to make sure that that bill for that, 1-inch laceration is not excessive and that we're not being upcoded, which EM has, of course, been found guilty of multiple times. So, I mean, that's like the basic level kind of thing I think are important. I don't think the individual doctor can advocate for that. I do think they can support those who are advocating for it and force the college to do it. Certainly AM is going to do it, take medicine back, write letters, speak up. Your voice is heard. You go to your congressman from your district as a physician, they're like, yeah, tell me. I want to be informed. It's amazing the power you can have as an individual doc to spread the word, but it's got to be led by the professional societies.
We're in this No Surprises Act landscape now. Insurers have been able to take advantage, terminate contracts that have been around for years and years, reduce in-network payment levels, and then when out of network, reference all of those declining payments to create sort of a QPA construct that allows them even to reduce the out of network payments, right? And they've created this landscape that works to their advantage. Any thoughts or suggestions? So at the end of the day, revenue needs to go up to be able to support the compensation that seasoned, talented physicians deserve and are need, as you put it, to be able to retain that talent.
Insurers are just as bad as private equity, right? They're the two evils, right? And we decided to side with one, private equity, to quote unquote fight the insurers. I think we made as I always say, a Faustian bargain there. People in Congress saw us arm in arm with private equity, like these emergency docs want to rip off the public, and like, who's got more money? The insurers, they're going to give more to my campaign than private equity will. And it's kind of easy to see where we lost. How do you reel in the insurance industry? They've got huge power. I don't know. I saw it coming, but the powers that be in organized emergent didn't realize that the insurers would say, why don't we own the physicians? And now Sound Physicians owns emergency medicine. Optum, 10% of all physicians in the country are owned by an insurer. Is that crazy? It's up to the next generation. And I see the movement that we got to say, an insurer shouldn't own a physician. That's the illegal corporate practice of medicine. That is a total conflict of interest. Decisions are going to be influenced by an insurance company. Like, no, you don't need that medication. No, you don't need that test. So my only hope is it's the public. We got to count on the public. There's got to be an outcry. There's been some success against the insurance industry. You saw that the AMA just got this whole thing about pre-auths. I mean, if I'm sitting in the insurance industry, I got to say, like, who are the bad guys here? It's not the small emergency medicine physician-owned group who's only been billing us, reasonable amounts. They're not. We don't want to take them down. We want to boost them up, and and then look more at the problematic groups that are billing 8 to 9 times the Medicare, the PE companies and whatnot, and kind of see the specialty for what it is. I don't know if that's happening there. Private equity is not emergency medicine. The doctors do not want this. But again, we've had to consolidate too, right? I mean, like, look at Vituity's taking off because they're bigger, they got clout and they're physician-owned and people want to work for them. It's not like the ideal situation, but it is at least physician ownership. So I see hope in the future. I think PE is going away. After the collapse of Envision, American Physician Partners, with the debt that Team Health holds, I think they're going to be sliding out. The question is, what do we replace them with? Some circumstances are going to be hospital employment. That was a problem at the start of the specialty. Hospitals would employ docs and suck off the revenue. Doctors, you own this stuff. You don't really need a whole lot. You hook up with a good revenue cycle management company. They'll give you the data. They'll let you know. They'll help you negotiate with the insurers. Bring in some business skills. Hire somebody who can help you do that. Reestablish control of the practices using professional assistants to make sure it operates as a business that can compete and give salaries that will help sustain long careers in emergency medicine.
And your passion for that is what Eliot and I also share, and is the reason for Elia Group to exist, is because we are taking back the right of the practicing physician to receive fair payment from the payers. Through litigation, we finance litigation against payers who are just going to pay you next to nothing. I think it's going to create a greater transparency and accountability as lawsuits are adjudicated through the courts, and payers are found liable for the things they have refused to pay for years. And so that's part of my passion. I share it, as you know. You and I have kind of gone through our course of the career kind of side by side, me on the reimbursement side. Funny side note though, Bob, you might not even know this, but I started my career where you started your career, at MCP. That was my first job after graduate school, was billing support for the Department of Medicine, Department of Surgery at MCP, 1979. I met David Wagner. I did some consulting with him. Those are treasured times for me, starting my career. You and I got started in the same place. But and I think today we're sort of in the same place in terms of advocacy and passion for the specialty.
Emergency medicine has been awesome for me. It's been very fulfilling. We got to keep it that way. We've got to restore some physician leadership to get back the integrity of the specialty. I mean, we're founded to serve a public need, and now we're trying to do that while serving an industry that wants to profit handsomely off of us. And it just doesn't make any sense.
But Bob, what do you think? You mentioned Vituity, which is a physician-owned, quote, democratic practice. Do you think that's a positive trend in the industry to have a group like that to be able to grow at the pace they are and arguably be competitive with private equity?
Yeah, absolutely. So, I mean, they used to be California emergency physicians, right? And they actually at one time were with the EMA group of the North Jersey area that actually wound up selling to Envision. So, I mean, CEP could have gone that way, right?
Yeah.
I mean, that was a $370 million sale for those senior docs in North Jersey to Envision. That anecdote I gave you about the doc who was supervising too many non-physicians, I'm pretty sure that was an old EMA contract that maybe back in the day, if they had retained physician ownership, it wouldn't have been 3 non-physicians supervised by 1 doc. So maybe the patient that was harmed got harmed because doctors decided to cash out. CEP became bigger, became Vituity. I can tell you that they don't fit the ideal definition of what the American Academy would say. The partnership track is tiered, but there is a partnership track. So I think, and I said this many times, if Vituity was the worst out there, there would never be something called the American Academy of Emergency Medicine. I have docs who graduated my program who work for Vituity. They give positive reviews. To me, that's the best thing, that somebody I trained who I trust saying, yeah, this isn't, I'm not like a partner, after a year or two, but, once I get there, I feel this company's doing right by me. So if you're sitting in Vituity's shoes, like all the efforts of the Academy, I hope they're cheering us on. They ought to be, because, taking out private equity, that creates opportunity for them. It would be our worst day if I heard Vituity sold out to private equity. I don't think it's going to happen because I don't think private equity is going to buy them. And they have promised that they're not going to do that multiple times in public forums. But then again, right, people promise things all the time, as we're witnessing in our current political world. Only trust your family, right?
Well, Bob, thank you very much for your own transparency about what's going on in the profession. Continued success with your leadership, both within Temple and within the organization, to having the impact they're having. Thank you very much for joining us. Appreciate it.
All right, my pleasure.
Thank you for listening to The Strain. Please subscribe and listen to The Strain wherever you get your podcasts. The Strain is sponsored by Eliot Group, financing healthcare litigation.